China. It's not Germany. It's Khartoum, China. Wei
Okay, good morning everybody. To get very close in this program, we have very exciting talks. I'm sure you're going to enjoy them. It's a very important thing to use. That I actually visit Heidelberg more than 4 times, which is one of the very early universities in Europe. First university in Europe. It's a university city. It's a historical site. Inspiring place. I wish you can use the Institute for Heidelberg for some time. I think some of you will be out there. Why don't you ask them to move here because they have a space?
Heidelberg University. It's a pleasure, in fact, a pleasure and honor to have Professor Mishai Kishfing on this beautiful day. And also to have it in our second station, the Institute of Endemic Diseases. Professor Kishfing is an eminent professor of immunology at the Institute of Immunology, Heidelberg University from Germany. Heidelberg University is one of the oldest universities in Europe, and it was founded since 1786, so almost 625 years old.
Thank you. This weekend.
Is it this weekend?
Yes.
I will just go brief on CV. Born on 14th October 2nd, 1952. 1983 he got his PhD in experimental pathology. 82-85 postdoctoral fellowship at the Institute of Immunology, Heidelberg University. 85-87 postdoctoral fellowship, Cancer Institute, USA. 87 head of the Laboratory of Immunochemistry, Institute of Immunology. 1999 through 2006, chairman of PhD committee, medical faculty, University of Heidelberg, professor of immunology in 1999, faculty representative of the Heidelberg Tongji, China University Partnership Program. In 2003, awarded teaching award of the state, and Professor Kishfing is a member of various scientific associations, societies, and editorial boards. He will deliver a series of lectures. Yesterday he presented or delivered his first lecture on the introduction of his beloved topic or the area of interest, which is these lectures focus on the importance of complement in different areas, including complement analysis, evasion. That will be on the strategies of pathogens, therapeutic, inhibition, and cancer immunotherapy. In addition, he is an expert in the field of developing a new medical tool. Hopefully on Wednesday he is going to give a seminar on probably-based learning in addition to development, his experience on the development of the May I ask him to present the second lecture?
So I would like to thank you for inviting me to give this talk here. It's a great pleasure to be in Sudan and to be in Khartoum. And actually, the reason I'm here is that I had a fellow from Sudan, from Khartoum, from the Faculty of Laboratory Medical Science, spent some months in my laboratory to do part of my master thesis. Very interesting, very important field. And so all the time I thought once I have to go to Khartoum to see where she's working and what is going on in Khartoum. In addition, I have a very good friend, old friend, Professor Mohammed Idris, who is from Khartoum, but he's now working in Oman, in Muscat, he's a professor. And so it's really nice to be here. It's a little bit warmer than in Heidelberg. In Heidelberg, when I left Germany, it was about 2 degrees, a little bit freezing. And here I have more than enough sunshine, so I will bring back some sunshine to Germany. So actually, those who have been attending my previous lecture yesterday, they will recognize some slides because I will start again to give a general introduction, and I will also start again, I hope you will find interest in it, to give you some pictures from Heidelberg and the University of Heidelberg. Because I've heard some of you have been there, but not everybody. So I hope I will not be in the way. It's not easy to find the right place. So this is the Heidelberg University. This is not the university is located there. The new university, the old, which started more than 600 years ago, everything was located here, which is the old city of Heidelberg. This river is called the Neckar River. It's a small river comparatively, and this valley here, on this side are mountains, and on the opposite side, 1 kilometers away, there are also mountains. This is the so-called Rhine Valley, and the Rhine is the largest river in Germany. So this is the part of the old castle, which is partly in ruins, because we had a couple of wars in the last centuries, especially with our nowadays friends, but at that time they were not really friends. The French people, and so this is a view through the castle. You see there are still some ruins, and some buildings are nice. This is the old bridge, it's part of the old city, and this actually was the foundation of the first big university clinic, which was between 1866 and 1876. This area here was still this clinical institution, and the location of the buildings and running waters offers a great advantage to avoid infectious diseases. Thus, the excrements may be disposed in the best way. So this was more than 100 years ago, the thinking of hygiene, and still very few of the clinics are still there, but all the new clinics are moving to the new campus. So this is another picture of the castle. These are all the new university clinics here with internal medicine, very big. This is this is so-called head clinic, which was a new invention even in Europe. That every discipline which has to deal with the head was integrated in this clinic. So neurosurgery and dentist school and head, neck, and ear disease, and everything was here. And here are the scientific institutions, so we have a very close relationship between the scientific institutions. So just to give you some numbers, every year 1 million people come to visit Heidelberg. Heidelberg is small, you have seen. It's 130,000 inhabitants, so it's really small in comparison to Khartoum. And it has 35,000 students, so every fourth person is a student. So this is a nice relationship. So with 1 million visitors, tourists are coming, and we have so-called visitors, our patients, 687,000 per year in our clinics. And the average stay for a visit of a tourist is 90 minutes. in Heidelberg, so they are coming. Heidelberg is quite small, and so some still shorter. But of course, if you are patient, you need to go longer in clinic. So the average stay of the patient is 1,000 minutes. So with the ambulance, of course, and most of them are, of course, outpatient. So this is the entire view of here is the old city of Heidelberg. The river is coming out here, bending me around. And here there's the entire campus, which has all the clinics, but also has some faculties of natural sciences. And it also has a large National Cancer Institute, Germany, which has about more than 2,000 scientists. And on top of the hills, we have the European Molecular Biology Laboratory, which is also 2,500 scientists. And we have a couple of so-called Max Planck institutes, which are research institutes of different kinds, not only medicine, natural sciences, life sciences, social sciences, and 5 out of these institutes are located in Heidelberg. So today it's a kind of center of biomedical research, and this makes it very attractive to work there because you find all disciplines, you find experts, and it has been hosting Nobel Prize winners. I think we did have 9 or 10 Nobel Prize winners over the last years. So this is just a little introduction to let you know what the is about. Heidelberg tree is much smaller than here, and it's a little bit greener than here because we don't have so much sunshine. We have a lot of rain, and we could actually transport some rain to Khartoum, and we get some sun back. So these are the locations of the clinics nowadays. Some are still in the older part, but most of them. Okay. The focus of my talk today, Professor Rata already mentioned that it's a series of talks I'm giving. I have to admit that I've never given so many talks like I should give in two. Coming from one visit and giving 8 talks is a lot. So yesterday I started with an introduction to complement research is my research field. I'm actually, in the last years I focused more on tumor biology, and you have heard from my CV, I spent some time in the German Cancer Center, some time in the National Cancer Institute of the United States. So I feel really bound to tumors, but I'm primarily immunologist, so I try to find ways how the immune system deals with cancer. And this will be the topic of my talk tomorrow. But today I will give you a brief introduction to complement first, and then I will talk about the modern analysis, the possibilities we have today for diagnosis in the clinic on the one side, but also for analysis in research. And this afternoon I will talk about immune evasion of my pathogens, and with particular focus, of course, again on complement, because microorganisms, especially pathogens, have developed lots of strategies how to evade the immune system, you all know, but in particular also how to evade the complement system. But this will be this afternoon, and so let me start with the introduction. This is, you can imagine, this is almost 100 years old, this drawing, and this was done by a famous German scientist called Paul Ehrlich. And Paul Ehrlich thought the complement system would be a molecule which on the one side connects to an antibody. The antibody is then binding to, for example, E. coli bacterium or some parasites, or it could also be a cell where an autoantibody is binding to. And then it has the binding site, and it has the so-called toxic site. But of course you didn't know that this system is a huge system of many proteins. Now we know that there are more than 35 proteins acting in a cascade-like reaction. I will show you briefly. I went a little bit more in detail yesterday. And regulatory proteins in the fluid phase and on the surface, and a couple of receptors. So I will give you a short introduction to the system, and then I will talk a little bit about deficiencies, and then analysis of course. So I usually start just to indicate how the immune system built up, and you know this, of course, the specific adaptive immune system, and what is much older and probably more important is the innate immune system. With macrophages, natural killer cells, and here you see a complement which is in this branch, the innate immune system, in the humoral part, so in the fluid phase. This is one part. More importantly, from the viewpoint of complement, is that complement is interacting with all these cells. So because these cells do have receptors on the surface. And not only the cells of the circulatory system, of the defense system, but also the cells in the tissue, everywhere. And this makes it very important complement. And it's not only what we all have learned in the textbooks that complement is killing bacteria, lysis, but it's much more. Because the reason why cells do have receptors is, of course, that they expect to get a signal from the system and then to act in a certain way. So complement is involved in the regulation of the adaptive immune system by interacting with dendritic cells, with lymphocytes, with T lymphocytes, B lymphocytes, and it's also acting in wound repair, in all kinds of other homeostasis associated situations. So and we still are not at the end of research to know what is complement all do. So complement is, since Janeway and with bringing back the importance of innate immune system on stage, we know that the innate immune system, like the adaptive immune system, has a possibility to recognize very specifically certain signals, danger signals. So this danger is coming, of course, primarily from outside, the invaders, the pathogens, viruses, bacteria, parasites. But on the other side, we also have a danger signal coming from our own body. We have dying cells, we have apoptosis, and we have destroyed cells after, for example, an accident, severe accident, after burn, or in cause of severe infection. And those cells which are altered, they need to be eliminated. So this is also a kind of endogenous danger. And so we have some signals. So you have heard about the so-called pattern recognition molecules. These are molecules on surfaces which are recognized by the innate immune system, especially by the so-called toll-like receptors. And but these pattern recognition molecules, they are also existing by the action of complement. So we have something which looks like a bunch of tulips, flowers. This is mannose-binding lectin and picoline, C1q, and another molecule, coferdin. And these soluble immune sensors, they lead to the activation of complement. And in the center is the most important component is named C3. And then the build up, or then the generation of the menin tech complex occurs, and this leads to lysis, killing, or activation. And on this way down this cascade reaction, because it's an enzymatic reaction, meaning that from a protein part is cleaved off, and this small part is very important. They have signal function and they interact with receptors. And you see many of these receptors, or many of these peptides, different forms of these three metabolic peptides, they are interacting with receptors on the surface of the cell. Complement receptor 1, 2, 3, 4, C3A receptor, and then more C5A receptor, and these are regulators. So this is danger transmission. And here we see what happens. So either by the attachment of mannose-binding lectin to carbohydrates for under pathogen cell which is destroyed, or of the classical pathway via antibodies in the Q. The classic pathway is activated, cleaving of C4 and then of C2, and then we have a molecule which cleaves to 3, and then the release of peptides out of the cascade on the bacterium on the parasite, these are covalently bound. Reactions going on, C5 activation, and then another very important peptide C5A, maybe the most important or potent inflammatory peptide is released. And then the cascade is concluded to the membrane effect complex. And then we have a further metabolism of T3, and they find their own receptors inducing phagocytosis, infections, and so on. And this brings it to the biological function, to the lysis, which we know already. But more importantly, the exploration and the recruitment of the cells to the place where the infections, for example, is going on. And there, of course, we need a proper opsonization. And opsonization, there are more opsonizing molecules like immunoglobulin G, and MBL, and CRP, and so there are a couple of opsonizers. But complement also brings in two new opsonizers, which are C3b and IC3, with two different receptors, very potent in inducing phagocytosis. Very important is also the elimination and regulation of immune complexes, because we do have immune complex generation every day, a lot, and they need to be balanced and keep on a very low level. Otherwise, but only by their size or by their specific interaction with tissue, they're stuck in the small vessels of the skin, of the joints, or in particular also in the kidney, and induce severe so-called immune complex disease. The complement is very important in eliminating these immune complexes, and this occurs with erythrocytes. They should be red, also one color. So erythrocytes carry, because they have a C3 receptor, and immune complexes activate complement, bind C3b, and this interacts with the C3 receptor on the erythrocyte, and they carry it to the liver and spleen, the so-called reticuloendothelial system, and there the phagocytes, huge amounts of phagocytes are sitting and taking over the immune complexes, and the erythrocytes recircle to the bloodstream. And then, what I mentioned before, the interaction with all these cells of the adaptive immune system leads to the regulation of the adaptive immune system. So this is a picture I have shown also yesterday, indicating that complement is a very powerful inflammatory system. And inflammation, of course, from the clinical view, is often considered only to be pathological. But this is not true. Inflammation is required. It's absolutely required for each defense situation for our immune response. Of course, only to this point here, where we have edema formation. We have the hyperemia. These are Latin words. We have to learn Latin. Calum means heat, and rubor is the redness, the hyperemia, the red color. And the tumor is not the cancer tumor, it's the edema formation. And edema formation is very important to get the proteins, the defense proteins, the cells outside of the circulation to the place where they have to act, to the place of detection, for example. Only if it goes to this direction, that we have pain, and we have a laser, which means a loss of function of the organ, a damage of the organ, then of course complement is not regulated any longer. This requires, I mentioned it, regulation. Such a powerful system, which may also act against the own body, needs to be regulated very tightly. And so we have many regulators in the fluid-based blood, C1 inhibitors, binding protein, and these are two regulators of the alternative pathway. These are two regulators of the sequence which leads to the generation of the membrane effect complex. And this is a regulator very important for the peptides, small peptides like C5A and C3. In addition, on all the surface of our cells in the body, every cell in our body needs a couple of receptors, regulators on the surface. These are regulating C3 activation, and this is a regulator of the tongue. So how do we proceed with analysis? Now I come to the analysis, what methods we are using, and where we need it, particularly, of course, in the clinic, but also used in research. So we follow a certain algorithm. So we start to take an overlook on the system. And this is done that we look for the function of the classical pathway, the alternative pathway, and the third, selective pathway. And then this is followed by the analysis of individual complement proteins and regulators. Most of this analysis is done in serum, but also in plasma. And you see we can diagnose all these different proteins, inhibitors, in their concentration, but also in their function. Then, if we want to know if the system is activated and how it is activated, then we have specific test systems, mostly ELISAs, and this needs to be done in EDTA plasma. This is very important because if the blood starts to clot, then the clotting system is activated. This is due to the clotting system. And the enzymes which are in the clotting system are so-called serine proteases. And those enzymes are also able to activate complements, C3, C1, C3, C5. So if we have a normal clotting of the blood after we have taken blood from the patient, for example, and we use the serum, then in this serum artificially complements activate. And this is avoided if we take plasma, EDTA plasma. Why EDTA plasma? Because this chelates, this binds calcium and magnesium, and these two ions are absolutely required for the action of complements. So by taking away calcium and magnesium with EDTA, no artificial activation of the complement system occurs when we draw blood from the patient. And so we can use the EDTA plasma much better as a matrix for analyzing this activation products, which may be cleavage products, or complexes which are generated in course of the activation. Complexes of the enzyme and the inhibitor, which is on all these stages. In addition, we have a couple of autoantibodies which are directed against complement proteins or complement regulators, and they are in association of certain diseases. And so we also need to recognize them. This one is the so-called nephritic factor, which is an autoantibody against the C3 convertases, and this stabilizes enzyme so that we permanently have a turnover of T3 and a huge amount of inflammatory peptides and inflammation in the subsequent situation. We have autoantibodies against Q, which is very often seen in lupus. Then we have autoantibodies against C1 inhibitor, the regulator, which we see in some patients who have a disease called angioedema. So may I ask, who is a doctor? Hands up. Oh, so few doctors. So I have to pay attention to the fact to explain some disease. I thought they were not doctors. So, the complement analysis, how is it done to measure the function? And by tradition, but it works very well, and it's not difficult to establish. We use erythrocytes from sheep, or from chicken or rabbit, and the sheep erythrocytes we bind antibodies. We have immunized rabbits with sheep erythrocytes, so we have an antibody against sheep erythrocytes, and so we have an antibody-antigen reaction which induces the classical pathway. Whereas the rabbit and chicken erythrocytes, they are able to activate the alternative pathway without anything else. So we add now serum. Here we use serum in different concentrations. And then the cascade runs on, and if it is successful, and the patient or the individual has all proteins, then we get nice lysis. If we do not have lysis, then we have to check for individual components. if you do not have lysis in this classical pathway assay,